Good morning. Thanks very much for the introduction. So this is a very broad topic, so I'm going to move right along because there's a lot of information and I don't want it to come across too quickly, and hopefully there'll be some salient points that sort of stick, and we'll just see how things go, all right? So what is Parkinson's disease? That's obviously the root question of this talk. Parkinson's disease is a neurologic condition that affects the brain. It's generally a slowly progressive disorder that primarily affects the motor system, so it involves movement, rather than, say, cognitive issues, which tend to be less prominent in Parkinson's disease, unlike other neurologic conditions, but can be part of Parkinson's. Generally speaking, it causes stiffness, slowness, sometimes a tremor, but not always a tremor, and balance difficulty. And over the last several years, there's becoming more recognition of what we call the non-motor symptoms of Parkinson's disease, symptoms that can be very bothersome to patients and in many cases can be treatable as long as they're recognized or observed, and can be attributed to Parkinson's disease sometimes, and in other cases not necessarily. But when we talk about this being a motor disease, the motor symptoms essentially are coming from a lack of the brain producing a chemical called dopamine. And that's an important point, the dopamine. Next slide. So what is dopamine? Dopamine is a neurochemical or a neurotransmitter. Essentially, when one brain cell sends a message to another brain cell, it has to do that by some sort of intermediate, which is a neurotransmitter. It's a chemical that sends the signal to the next brain cell. And dopamine is an example of that. It's released by one brain cell, and then it attaches to a second brain cell and sends a message to that brain cell. And that's how the brain communicates within itself and with the body. Dopamine is made specifically in a part of the brain called the substantia nigra. And that basically means dark substance. And that's because in the process of making dopamine, one of the things that's also produced is melanin, which is what makes moles or freckles. And so there's deposits of melanin in this part of the brain that create this darker appearance. And that's where it gets its name. But these cells are sort of located in one spot. They produce dopamine, and then those neurons project to other parts of the brain to communicate signals to affect the motor systems. But dopamine has a role in motor issues. It also can play a role in some cognitive processing and also in emotional circuits and things that drive motivation. Next slide. So this is a picture of, first, the original essay written by James Parkinson in the early 1800s that described initially what was called the shaking palsy, which some people have heard that term. But this was the original description of Parkinson's disease. And this picture on the right is actually a slice from a part of the brain called the midbrain, which is deep down in the brain. And in this structure, you see the dark area. And that dark area is the substantia nigra. That's the part of the brain that makes the dopamine. And what you see on the top is a patient who does not have Parkinson's disease. And you see how deep and dark it is on both sides and fairly symmetric. What you see on the bottom is the same part of the brain, but in a patient with Parkinson's disease. And what you see is there's less of that darkness there. And what's also important here is that it's asymmetric. And this is another important point. It's actually darker on the left side of the screen than it is on the right, and that's because what you see in Parkinson's disease is that one side of the brain is affected more than the other side of the brain. And so very commonly, symptoms will begin on one side of the body, and then maybe over time, eventually involve the other side of the body, but that there's an asymmetry, that one side tends to be worse than the other side. That's almost a diagnostic criteria. It's so true to most patients. Next slide. So Parkinson's disease is a disease that primarily affects folks in their 50s, 60s, 70s, older decades, but it can affect people as young as their 20s and 30s, less commonly so, but it can. The primary age of onset is usually between 40 and 70 years old. There are at least 1 million people in this country who have been diagnosed with Parkinson's disease, making it not a rare disorder, but not a common disorder. But if you take the population over 65, at least 1% of that population as a whole has Parkinson's disease. So if you have a movie theater full of folks who are over 65, you're going to find a handful or more folks who have Parkinson's disease. Prevalence is another way of sort of assessing how many people in the population, and if you just took 100,000 people out of the population, 160 or so, maybe even 200 in some cases, would have Parkinson's disease. So I'm always asked, well, what causes it? I mean, that's an important question, and that's part of why we have scientists, and what we're always trying to figure out is what is the cause of a disease. The better you can understand the cause of a disease, the better you can then find treatments for that disease or stop the process that's going on. The exact entire story is not known. That's why we continue to pursue this. But there's a lot of information that we do know that gives us hints and clues about what may be going on. And the sort of sum total of that is that the current theory about Parkinson's disease is that we do have some genetic components that may increase our risk of developing Parkinson's disease. By no means a guarantee of developing it, but that there's a higher risk than maybe someone else based on our genetic code. But that there might be things in the environment that then maybe tip the scale or increase that probability or risk, and then it occurs in that individual. But in 95% of folks, it really is a sporadic condition, meaning it just happened. It's nothing that they did or nothing that they did wrong or nothing that their parents did to give them that caused the disease. It just is a matter of probability, and it just occurred. So when I say it's genetic, that's to distinguish it from being inherited. Something that's genetic isn't necessarily inherited. And so really it's rarely an inherited condition. That's another common question I get. Only about 5% of people who have Parkinson's disease have an inherited form of Parkinson's disease. And most of those people are really the young onset Parkinson's patients. So if your parent was diagnosed with Parkinson's disease in their 70s, it's really unlikely that that's an inherited form of Parkinson's disease. So how do we diagnose Parkinson's disease? Well, up until recently, Parkinson's disease was not diagnosable by any particular test. It's not like you would do a biopsy or a blood test or an MRI or a CT scan and go, oh, there it is. It's definitive, it's Parkinson's disease. The way we would diagnose Parkinson's disease is based on the history and the physical exam, which is really sort of nice for a physician because that's what medicine is all about, is being in the exam room with the patient, getting a history, doing a physical, and then being able to make a diagnosis. But it is reliant on that history and physical, so there's a lot of subjectivity and human error that's introduced into that. You know, the quality of the history and the features on the exam, and of course there are a lot of things that can confound that. But what we look for on the exam, well, I'll explain that in a second here. So when someone comes in and there's a concern about Parkinson's disease, the diagnosis may not be made by lab work and imaging studies, but lab work and imaging studies will be part of the evaluation process because they might be looking for other conditions or things that can sort of mimic or look like Parkinson's disease. So certain issues can create a tremor or cause difficulty with gait or balance, and that can be due to some other process that might be diagnosable by an MRI of the brain or some blood work. And certainly there are things in the history and the exam that might lead you to think about things that aren't quite Parkinson's disease. But recently the FDA actually did approve a new study that's only recently, actually they approved it I think last year, and it's only recently been available in the Richmond, and they do it at the VA and downtown at MCV, I believe. And it's called a DAT scan, and let's see, did I mention it here? Let's see. And what this scan is able to do is it's actually able to differentiate Parkinson's caused by a lack of producing dopamine from other things where that's not an issue. So for example, folks with essential tremor, where they have a tremor but they don't have Parkinson's disease, they're not having an issue with dopamine, and so this study will look, the dopamine part of the brain will look normal, and in a Parkinson's patient you'll see a reduction in that dopamine production. And the way this study works is we inject through an IV a radio tracer that binds to that cell that makes dopamine. and essentially it lights up on the image, and you see a very clear picture. And there's a distinction between what someone who doesn't have Parkinson's disease would look like and someone who does would look like. Go ahead to the next slide. And this is an example of that picture. This is called a DAT scan. DAT stands for dopamine transporter, DA for dopamine. And in this case, you see the picture on the left. We call that the comma. It's sort of a period with a tail to it. And that is a patient who does not have Parkinson's disease. Now, it doesn't tell you what they do have. It could be essential tremor. It could be any number of other things. But the patient on the right, we call that the period. You sort of lose the tail of the comma. And so that dot there shows that there is a reduction in those dopamine-producing cells. And that's been fairly definitively good at diagnosing this lack of dopamine. But because in the clinical setting it is often fairly definitive based on the history and the exam findings, it's not really necessary that every patient gets a DAT scan. In fact, there's probably a small number of patients in the overall population that really need that scan, and there are a lot of circumstances that might determine whether that's a good idea or not. But when you see what we call the cardinal features on the exam, you can be fairly definitive about the fact that you see Parkinson's in a patient. And when I talk about cardinal features, this is when we get into the way we teach medical students, sort of textbook things. What are the most important things you see in a patient with Parkinson's? And what those things are is a resting tremor, and that's to distinguish from other types of tremor that occur during action or maintenance of posture. A resting tremor occurs when you're at rest. So someone who's sitting down in a chair, watching a ball game, getting a little nervous because it's getting tight, and they might start to tremor. Or sitting at the table, and the hand might start to tremor, or the jaw might tremor. That's a resting tremor. That's not a requirement for a diagnosis of Parkinson's disease. And a lot of folks who have Parkinson's disease will not necessarily have tremor. What is a requirement in order to diagnose Parkinson's disease are the next two things, which are bradykinesia, which is a term that means slowness of movement. So brady is a medical word for slow, and kinesia is like kinetics, is movement. So bradykinesia is the term we use to describe a slowness of movement. And that's manifested by handwriting taking a long time and getting small, gait slowing down and becoming more of a shuffle, and just sort of a more deliberate slowness to general movements. And the other thing that you do need as a requirement for the diagnosis of Parkinson's is what we call rigidity. And rigidity is when a doctor is assessing your muscle tone. And muscle tone varies from one person to another. And it varies when there's issues with the neurologic system. And what you see in Parkinson's is an increase in muscle tone, a tightness that tends to be kind of stiff, is what we say, a stiffness that you feel in the neck or in the arms and legs. So that bradykinesia and that rigidity, that slowness and stiffness, that's really the core of Parkinson's disease. One of the other symptoms that you see in patients, typically further along into the disease process, is something called postural instability, which basically is a balance issue, where you feel unsteady on your feet and you feel like you're going to fall backwards or over. And that's a fairly important feature. But there are lots of other features that sort of go along with Parkinson's disease. Not every patient's going to have everything. So if you read about it, you don't go, okay, when's that going to happen? When's that going to happen? When's that going to happen? The issue with Parkinson's is it's very diverse, and there's a lot of subtlety and differences from one patient to another. The core features, the bradykinesia and the rigidity, are the ones that are consistent. But other features that we do see, as I mentioned before, is this asymmetric element, that there's asymmetric onset, meaning it starts on one side and progresses to the other side. And the other important feature in classic Parkinson's disease is that the patient's symptoms get better with medications, with the medications that we use. So some other symptoms that you might notice or that you might get in the history is that the patient is having a shuffling gait where the feet sort of shuffle along the floor. That the handwriting may start out big and then trail down and get smaller and smaller as you're going. one thing you notice is that there's a decrease in sort of facial expression. That goes along with this sort of slowness, that the face sort of becomes less expressive. And we call that masked faces, just more medical stuff, but it's a loss of facial expression. Another symptom that folks will notice in some patients is that their speech gets quieter and softer, and in some cases can be sort of mumbly. One of the earliest symptoms of Parkinson's disease that is well recognized but very difficult to sort of elicit historically is that folks will lose their sense of smell, oftentimes maybe years before they develop any other symptoms. And that manifests with things just not having the same taste, essentially. It's not a loss of taste, though, it's a loss of smell. So things might just, you might want a little extra salt on things or a little extra spice just so that food has more flavor. And other things that we see are issues with sleep. So there's a higher incidence of things like sleep apnea. People can have issues where they act out their dreams and move a lot and kick and scream in their sleep. Or just things like restless leg syndrome, which is very common in Parkinson's disease, where you have an achiness in the legs at night when you're sitting still and you feel like you need to get up and move around. Here are some examples of what we call non-motor symptoms. So these are symptoms of Parkinson's that aren't necessarily mediated by dopamine, but they're still part of the disease. And that's things like depression and anxiety, and we do see that there are changes in people's mood in some cases. Sometimes people deal with issues of lightheadedness when they stand up, where their blood pressure seems to drop. Urinary incontinence can be a symptom. Like I said, this is not everybody gets everything kind of thing. These are just things that you might see in some patients. You see issues with pain, which often can be related to the stiffness. So if you've got a little arthritis in a joint and your muscles are stiff, it just makes that worse. Like I said, restless legs. In some patients, we do see trouble with memory. It's a subset of folks with Parkinson's disease, not in every patient. And it's not quite the same as something like Alzheimer's. It's a little bit different, but it can be there. And issues with vision, constipation, etc. So, okay. So this is a lot of information to. So I'm going to go through treatment, and this is obviously, this could be a whole talk in and of itself. I don't want it to go too quickly, but I'm going to go quickly through this slide. Really, the first question is whether to start treatment, and that's a whole topic in and of itself. The main point to take away there is that really treatment needs to be initiated when people are having symptoms that are affecting their quality of life. And that's a hard one to sort of call, but it's an important thing to work with your doctor on and be honest with them about. You don't need to stick it out and wait. There's no harm in starting a medication, which some people fear starting medication too early. Like if you start a medicine, it'll wear off sooner or stop working for you, and that's not true. It's really important that you treat the symptoms that are affecting you so that you can live a normal life and be very active. Other things that are important are exercise, diet, sleep, and you're going to hear a lot about things like that today, so I won't go into detail there. Go ahead, next slide. And like I said, are the symptoms bothersome? Which symptoms are bothersome? In other words, if you're bothered by constipation, you're not going to start dopamine. You might start medications for constipation. So you sort of have to get that information. But there are many choices to choose, and one of the decisions that has to be made, often with the help of your physician, is which medication to start. And this is sort of a list of a lot of the main medications that we use to treat Parkinson's disease. Really the key here is dopamine, and what we're doing with medications is we're affecting the dopamine system. At its simplest level, we have levodopa, which is L-dopa, which essentially is a chemical that is, you take a pill, it gets into your bloodstream, it gets into your brain, and your brain turns levodopa into dopamine. So it's sort of giving you back that chemical that you're lacking. And L-dopa comes paired with something called carbidopa, and everybody knows about, if they've been on this medication, carbidopa, levodopa, which is called Sinemet. And so that's one formulation of that. Another formulation of that is when that L-dopa is paired with a medicine called Comtan. And Comtan is another class of medication called a COMT inhibitor. And what it does is it blocks an enzyme that breaks down the dopamine. And so it allows you to get more of that levodopa into your system. And that's often paired with Sinemet in a medication called Stalevo. The Stalevo really is levodopa with a little more added to it. Another big class of medications, I didn't add it in this slide, but it's in another slide, is dopamine agonists, for which there are currently 3 medications on the market in the U.S. Requip, Mirapex, and I added it on another slide, is Nupro. And and the other one is MAO inhibitors, which are selegiline and rasagiline. Let's go along because I think I go into more detail. This is that example of the connection between one brain cell and the other, and that's where a lot of these medications work. In this picture, you see this larger part on top. That's the end of one neuron, and in those circles are small molecules of dopamine. And those are released into this dark space between the two cells, and they attach to these blue proteins down here, which are called receptors, and the dopamine attaches to the receptor to send the signal to the next cell. Well, levodopa gives you back your dopamine. The dopamine agonists work on the receptor. So those medications go in and bind to the receptor and sort of signal as though it's seeing dopamine without actually giving back dopamine. So levodopa I talked about. Levodopa, because you're giving someone back dopamine, it's the quickest, most robust way to improve motor symptoms. One of the downsides, though, is it's very short-acting, so you have to take it frequently. And initially, at least 3 times a day. But some folks, many years into their diagnosis, may be taking it every 3 hours or every 2 hours because it wears off so quickly. So that's a downside. The other downside to it is that at higher doses, not at the starting doses, but at higher doses, it can cause something called dyskinesia, which is a side effect of the medication. It's a sort of involuntary wiggling kind of movement. And that's a side effect of medicine and not part of the disease. I'd list some other side effects here, but I'm going to move on because we got it. Dopamine agonist is a big category of medications. Like I said, Requip, Mirapex, and Nupro are the main dopamine agonists. Nupro is different than Requip and Mirapex because it's a patch as opposed to a pill. And what's nice about that is it sort of gets smoothly into the system and sort of stays there continuously as opposed to having to be absorbed and then processed out of the system. But all of these medications do a very good job of controlling symptoms, but they can take a little bit of time to get up into your system. They have side effects that include